Welcome everyone to our June 2024 LabCoP Extended ECHO session. My name is Francis Ochen from the African Society for Laboratory Medicine, and I'll be your moderator today. My colleague Tapson Nyondo might step in just in case I run into any connectivity challenges. Kindly join our discussions through the chat. We do have language interpretation services, and we implore you to be on either English, French, or Portuguese. Stay off the off channel. Our session slides and recordings will be shared as soon as they become available, so you don't have to be taking pictures of slides as we run the session. Today, we will take a look at lab mapping journey and final data use, focusing on experiences from Malawi and Zimbabwe. You may be aware that the African Society for Laboratory Medicine, in collaboration with the African Center for Disease Control and Prevention, is implementing a lab mapping program in Africa. The aim of the program is really to contribute to lab network capacity strengthening through factual determination of where our labs are, what their capacities are along multiple domains, and what population are adequately served or covered by specific diagnostic services. Specifically, today we will be sharing the lab mapping journey for Malawi and Zimbabwe. Just to note that these two countries are pioneer countries that participated in the rollout of ASLM's Laboratory Network Leadership and Management course that has been running from about 2020. They will cover the rationale, processes, and how results from the exercise are being used or anticipated to be used in improving the performance of their respective national laboratory networks. And colleagues, to take us through this, we have two presenters from each of the two countries. And of course, they are doing this on behalf of their other team members. The first presenter will be Triza Sumani, and Triza is an Assistant Deputy Director, Health Technical Support Services for Diagnostics at the Ministry of Health in Malawi. Triza holds a master's degree with a distinction in biomedical sciences with a bias in hematology from the University of Westminster in the United Kingdom. And allow me also note that Triza is the first lady in Malawi to manage central hospital laboratories and also work at the Ministry of Health and really spearheading the affirmative action for women in that country in terms of, from the facet of the lab diagnostic services corner. Our second presenter is Vincent Campira, and Vincent is the National TB Laboratories Coordinator with the Directorate of Lab Services, Ministry of Health and Child Care in Zimbabwe. So colleagues, join me in welcoming our two presenters, starting with Triza. And Triza, let me take this opportunity to hand it over to you.
Thank you so much, Francis. And good afternoon, good evening, everyone on the call. We wanted to appreciate the honor which you've granted unto us, that we can share our experiences on the LabMaP exercise which we conducted in Malawi. So indeed, this presentation I'm making on behalf of the Malawi team. So I'll basically take you through a little bit of a background, and then we'll go into the processes that we went through as we did our lab mapping. And I will end by looking at the lessons learned and also the next steps. So Malawi is a pretty small country in the southern part of Africa, which covers an area of about 118,000 square kilometers. It has a population of about 20 million people. In terms of organization of the lab services, lab services are being delivered at 4 different levels: the primary, secondary, tertiary, and the national, whereby the scope of testing increases as we move from primary to national level. Just a reminder, laboratory services, they constitute a critical component in healthcare service delivery. Its role in disease diagnosis, treatment monitoring cannot be overemphasized. And as stipulated in the Malawi National Laboratory Operation Plan, the Ministry of Health in Malawi is committed to strengthening laboratory services by increasing accessibility to quality and the affordable laboratory testing. And the way to do that, Malawi embraced the laboratory mapping concept, which was grabbed after the nation went through a LabNetLead training course, where the advantages and the benefits of laboratory mapping came clearly strong. Just in simple terms, as we are talking about laboratory mapping, we are talking about the comprehensive GIS-linked process for data collection, storage, and analysis in order to unveil capacities within the network. So our motivation was really to strengthen the lab system by identifying gaps within the network and to know the targeted areas for capacity building. Where we have capacity, we also wanted to optimize those available capacities so that we are better placed as a country to support the routine laboratory testing, as well as to place ourselves in a way that we can be able to challenge all the disease outbreaks that are always hitting us. And of course, we want also to provide our visibility on the global, whereby we can have our own portal domain where people can access our information about our capacities in Malawi as a laboratory. The process started by having a target. We said, how many labs do we want to map? So our targets were set, as we can see on the screen, on level 1. On level 4, we only have 1 lab, and we wanted to map that one, and we went all the way to level 1, which is the primary level, and we wanted to reach 80% of those labs, which are constituted to 390 laboratories. After setting our target, we had to mobilize the resources, and of course, we provided training to make sure that every person who is going to get involved in the data collection is well placed to collect quality data. And this was supported by Africa CDC as well as ASLM. Data collection involved representatives from human and animal health, and also laboratory implementing partners that are supporting lab services in Malawi. It took a total of 6 weeks, where the 4 weeks was for the first phase and the 2 weeks was for the second phase. Data was collected using a form which was preloaded in ODK, and it involved taking GIS locations of the lab also determining the level of the lab and also looking at the different capacities in those labs. After that, data was validated. In the data validation, we're actually looking at the correctness of the data to make sure that we captured data as it ought to be. For example, we noted in the process of data validation that there were some confusions between biosafety levels and the biosafety cabinet classes. So we made sure that every aspect was responded to accordingly. And we also noted that we had some duplications. All those we needed to clean them and make sure that we have the data that is representative of what is on the ground, as well as data that can be reliable. And the cleaned data, the validated data, was analyzed using Microsoft Excel. That's just a picture of one of our colleagues taking coordinates at one of these health centers in the northern part of Malawi. On the results, we were able to map 462 laboratories. As we can see on the bar chart there, we were able to achieve the targets for the secondary level, tertiary level, as well as the reference level. On the primary level, we were not able to achieve the 80%. First, because we noticed that there were some labs which we were not able to categorize because our categorization for labs was based on the level of the hospital. So if the hospital is a secondary level hospital, the lab services are aligned to provide secondary level laboratory services. So for standalone laboratories, it was kind of difficult to categorize those. So that affected the number of the labs that we categorized as a primary. And also we had some challenges, as we'll see as we move on with the presentation, which also affected the numbers on the primary level. This slide just shows the cadre, the different cadres across the network. We see that from all the levels, we have 1,531 laboratory personnel. This excludes people who are working as laboratory attendants or laboratory cleaners. This is specifically for people that are providing laboratory services. And the different categorization is, as we can see from the top. I will not be able to go through each and every cadre in the interest of time. We also looked at the equipment available in the facilities. So we noticed that out of the 462 labs which were mapped, 401 laboratories had microscopes and 133 laboratories had gene experts. Biochemistry analyzers and hematology analyzers were available in 107 and 138 facilities respectively. The process really went on very good, but we had a few challenges. Challenge number one was the poor road conditions. So part of the mapping was done in the rainy seasons, and because of the rains, some roads were really bad to pass through. And as I also mentioned earlier on, we had difficulties to categorize standalone laboratories. So these were categorized as other. So apart from the 4 levels, which I've already talked about, we had another category which we named as other. And we also noticed that the ODK data collection form lacked inclusion of some of the key laboratory equipment. For example, we didn't have conventional PCR platforms in the form. That's just an example of how bad some of the roads were during the mapping, and this really affected us or stopped or prevented us to go to some of the facilities to do mapping. We have a lot of lessons that we have learned in the process. The first one was about the need for comprehensive training. This was to ensure that accurate data or quality data is collected during the process. So we made sure that everybody who was involved in the data collection went through the training which was provided by our experts, as I mentioned earlier on. The data collection ensured that data reliability and correctiveness. We understand the statement that says garbage in, garbage out. So we wanted to really have outputs that could represent and trying to make sure that our data is indeed what it is. We also learned that we needed to consider the best time to do the mapping as because of the experiences that we had with the roads. So we're saying, is rainy season the best, or we have to do it in the dry seasons? Otherwise, we noticed also that many things were changing along the way. New equipment was coming and additional people were coming, some were leaving. So we came to realize that laboratory mapping is supposed to be an ongoing process. So how did we use the data collected, or how are we going to use the data collected? So the data which we have collected has provided us with a clear visualization of what our services are like on the ground. So it's being used for informed decision making at the ministry level, for example, in terms of new equipment placement, and also even for HR deployment. And also, it's being used for mobilization of resources with the partners that are supporting laboratory services in the country. This data is going to be presented at the Diagnostic Technical Working Group, which we are having on the 25th of June, where we have all people that are implementing lab services, or everybody who is there in the diagnostic arena. So that's how our data is being used, and we also intend to use. It's all to be responsive to the findings of the roadmap. As some takeaway statements and also conclusion, we are saying laboratory mapping provides an objective way to visualize capacities within the laboratory network. And that is quite critical for evidence-based decision making, as the strengthening of the network. It is a powerful means for resource mobilization and also allocation. Validation of the data is a critical step that determines accurate data analysis, and also output. And is supposed to be treated as an ongoing process. This whole work wouldn't have been possible without financial and technical support from different stakeholders. We have the ASLM, Africa CDC, World Bank, Global Fund, and also in-country implementing partners that are supporting lab services in Malawi. Thank you very much for your attention.
Thank you very much, Teresa, for a very beautiful presentation there from Malawi by you on behalf of the Malawi team. I'll take this opportunity to introduce our second presenter, but just encourage us to continue sending questions and comments in the chat so that our presenters will then be able to respond to them both in the chat as well as when we get to the questions and answers. Allow me also note that our sessions are made possible given the generous support that we get from the Bill and Melinda Gates Foundation to the LabCoP project that is run by ASLM. Let me now hand it over to Vincent to take us through the second segment of this presentation, and then we'll get to the questions and answers. Vincent, over to you.
Good afternoon, everyone. I'm Vincent Kampira from Zimbabwe, going to give you some experiences from Zimbabwe as far as the lab mapping exercise is concerned. So what you see on your screens, that is the lab mapping team from Zimbabwe. And you can see also the supporting team from ASLM and Africa CDC. So in my presentation, I will look at the selection and coordination of the laboratory mapping exercise, the data collection, the tiered system for Zimbabwe, data visualization and utilization, and also the next steps. So for selection and coordination, the Ministry of Health team, animal health, environmental health, and the private sector, with support from ASLM and Africa CDC, we went through the LabNet leadership course, just like a team from Malawi. One of the assignments in the LabNet leadership course was to conduct a lab mapping exercise in the country. And this became our very source of motivation to do the lab mapping exercise, and also what we learned through the course in terms of the benefits of lab mapping for the country. The LabNet leadership team by default performed the lab mapping exercise. That is, the data collectors came from the LabNet leadership team, the mapping coordinator, and also the supervisors of the exercise. So what we did, we got a line list of public health laboratories and private laboratories from the Central Registry, which is our Medical Laboratory and Clinical Scientists Council of Zimbabwe. And from that list, priority was given to public health laboratories, especially the big ones, and across all the tiers. Just like Malawi, we wanted to make sure that all the reference labs are mapped, all the provincial laboratories are mapped, and also the central hospital laboratories. We also considered distance between sites, road network, available resources, and also to give a more representative picture of the diagnostic network. So what we did, the data collection teams were formulated based on the facilities to be mapped. After looking at all the information, looking at the distances, the roads, and also considering that It was during the rainy season, and we had to look at the routes and optimize so that we could map the maximum number of labs possible. And a WhatsApp group was developed to show progress during data collection and central monitoring through ASLM team. And most importantly, prior to the mapping exercise, a training was done. So this is just to show the Zimbabwe tiered system, where we have the reference labs at the top, central hospital laboratories, provincial hospital laboratories, district or mission hospital laboratories, and the lowest tier, the primary health care centers. In Zimbabwe, we have about 1,634 health facilities, both public and private. From the public sector, we have 10 provincial hospital laboratories, 5 central hospital laboratories, 102 mission or district hospital laboratories, and 111 primary health care lab centers. So from the mapping exercise, we were working with ASLM team, and they gave us some data tables from the data that was collected, which was hosted on the owner platform. And from the data tables and the maps, it made it easy to visualize our country data and to develop mechanisms to interrogate the data. As the lab mapping coordinator myself, worked on the data set at the first time and made the cleaning session for the first time. And then from there, ASLM supported the 3-day meeting where we have the whole LabNet team to work on the data cleaning processes and put recommendations as well as action items. So the main issues that came out during the data cleaning exercise, also like from Malawi, the biosafety levels of laboratories, the tiered system, how it related to the private laboratories, and also part of the animal health laboratories. Classes of biosafety cabinets, equipment, and interesting, the heat map, which was looking at testing capacity within the country, and also issues to do with affiliation of laboratories. So what we did during the cleaning exercise, we critically discussed on issues, identified, and we had to come to an agreement. I would like to say that coming to an agreement was not easy, but facts made it easy. And after agreement, that's when we started cleaning the data, inputting the correct information where errors existed. We also adjusted the tier system like Malawi did, especially for the private labs. They were then categorized as others, as well as the animal health and environmental health laboratories. We also used existing data sources to update equipment and classes of biosafety cabinets. From the program, the TP program, we have a list of biosafety cabinets that are within the public health facilities. Also the list of GeneXpect machines, as well as TrueNut machines. So these data sources were used to update our lab mapping data. We also made use of program data from TB, HIV, and malaria to adjust testing capacity as applicable. So this is a map just to show you the labs map in Zimbabwe. By affiliation, we have laboratories with an academic origin, our affiliation, NGO religious, that's where we have the mission hospitals there, private, and also the public facilities. And another map showing the laboratories mapped by the tiers. And as in the beginning, we mentioned that we wanted to map all the reference labs, the provincial hospital laboratories, as well as the central hospital laboratories. And this was a success. We managed to map all those big laboratories. And of the 266 labs mapped, 115 of them were public health laboratories. And these are the labs mapped to date. And this constitutes about 53% of the public health laboratories in the country, with majority of the unmapped facilities being from the lowest tier, the primary healthcare center laboratories. 107 private labs were mapped, and majority of them were located in the major cities, with the capital taking more than 50% of the 107 private laboratories. In Zimbabwe, you find that private labs are more located in the major cities, and especially in the capital, we have a lot of laboratories there. And this also increased prior to the mapping exercise during the COVID-19 era. And Zimbabwe intends to continue updating the lab mapping dataset. In terms of the next step, as a country and as the LabNet team, we need to continue using PlanWise to perform optimization exercises to improve the diagnostic network. Just to define, PlanWise is a web-based tool which performs population service coverage computations. You find that there exist many other tools to perform such computations, but PlanWise is extremely user-friendly. No special training is needed, but just a training package supported by ASLM. I have worked with other tools that can perform population service coverage computations, but PlanWise, thank you ASLM, this software is quite user-friendly. You don't need sophisticated training. You don't need to be a GIS specialist, but it's so user-friendly. So the Ministry of Health and Childcare, the Directorate of Laboratory Services will conduct a TB DNO exercise using PlanWise. We will also conduct a diagnostic network optimization exercise for HPV diagnosis capacity. And we are also planning to look at a replacement plan for the GeneXpert machines. In the country, we do have GeneXpert machines, which are a bit old, and we would want to use PlanWise to see the coverage that is in access to service by those machines, and if they break down, what it means to the population, so that we have a picture of the performance and how the population is being affected. In front of your screens, this was part of the DNO or the TB DNO scenario, where we're playing with PlanWise, and we used all the GeneXpert machines in the country, and we're looking at 50% capacity of the expert machines. Why? Because GeneXpert is a multiplexing platform which can perform tests, TB, HIV/VL, EID, COVID-19, and other tests. So using 50% capacity, as you can see in your screens, the coverage was 13.21%. And then we went on to add TrueNut machines, and we have 21 machines in the country. But you find that the TrueNut machines at the moment, they're only testing TB. So that's why you see the 100% on TrueNut there. And the coverage improved to 18.59%. As a country, we will continue running more scenarios to see where we need to place more labs. And as you can see in red, those dots indicate where there is shortage in terms of coverage in the country. So already we have a picture to show where we need to strengthen our diagnostic capacity, and we will run some scenarios in PlanWise to see where we can improve labs and where we can place new labs to improve the coverage. And then in terms of stakeholder engagements and partner support, we thank ASLM, Africa CDC, the Ministry of Health and Childcare, Directorate of Lab Services, the National TB Program, as well as the private sector for the important aspects they helped in the lab mapping exercise, as you can see. In terms of adoption process of the gaps and strategies for improvement, so after the cleaning exercise, the findings and proposed recommendations that we worked on as the LabNet team were presented to the Director, Laboratory Services. And this is a living document that we are working on online so that we can keep track of timelines and also keep track of what has already been implemented. All the findings and recommendations channeled through the Director, and action items shall be assigned as applicable to the LabNet team. And specific recommendations will also be followed up by the LabNet team members as applicable, because in the team, there's representation of lab coordinators, chief laboratory scientists, and other key personnel within animal health, environmental health, and also the private sector. The Directorate of Lab Services and the LabNet team are working together to start driving the implementation of the recommendations. For example, we noted that from the lab mapping data analysis as a country, we need to improve molecular microbiology capacity, as well as improve rapid diagnosis of critical pathogens. I think during the COVID-19 era, most countries came to reality and major improvements have taken place in several laboratories. So the Directorate of Lab Services has already engaged mobile diagnostics. These are the developers of the TrueNut platform, and DLS is in the process of performing in-country evaluations for influenza viruses, cholera, HPV, HIV-VL, and EID on the TrueNut platform. We are not only limited to this, but this is our starting point, and we hope to expand to other pathogens because the TrueNut platform is quite handy to use. It is battery powered. It does not require stringent environmental conditions, and also its ability to store or to give you an alert, which you can do further DNA analysis on other platforms. And previous DNA reports are available to complement the lab mapping data, and the future DNA exercise to be done, and those that are done already using PlanWise, we continue working on that as we improve our network. And like Malawi said, lab mapping is an ongoing process, and it is a living thing. And as a message to other countries, Zimbabwe has already begun to expand the lab mapping data. We are using, we are performing a TB external quality assurance supported mentorship visits in the country. And for that exercise, we moved from paper-based systems to electronic systems using the COBO toolbox. And what you see is already an indication of the implementation of that exercise. So far to date, as of today, we have 84 submissions, and those dots indicate some labs that have been mapped, because COBO toolbox is identical to ODK, but they're just different platforms which are easy to use, inexpensive, and freely available online. So our team, as we speak, they are already doing their mentorship visits, and as they do the visits, they collect coordinates for those labs. And we'll then work on merging the existing data in honor so that our lab mapping database is improved. So countries are urged to make plans to update their lab mapping database, make use of existing data sources to update your data, use PlanWise more, and explore endless scenarios. work as a team, and communicate your findings in real time. Never stop encouraging your team. Thank you for listening.
Thank you very much, Vincent. Fantastic presentation from the team, led again by Vincent. Panels contributed to this from the Zim team. And again, just to try and wrap it, lab mapping is actually not the end in itself. It is just the beginning. Because once you have very informative data, then you can determine the capacity across your public health labs, private sector labs, and even across sectors. You can actually get to the animal health, environmental health as well, and determine the capacities that are available there. They have also covered anticipation becomes available subsequent to a lab mapping exercise. I am aware that there are concerns around if you do the mapping today and a new equipment is brought tomorrow or somebody moves location. I am also still kind of convinced that if the movements out are balancing with the movements in, then the net deviation won't interfere with our valid ascertainment of the capacity that we have. Even when we do counting of the entire population of a particular country, you pass a household, somebody might unfortunately die or another somebody might be born. But the expectation is that that will balance out, and what you end up with is generally a valid representation of what you should be having. We have also noted that we have to take advantage of the available data so that we do not go out when doing a lab mapping exercise to look for even data that is available with us, but also take advantage of other data collection exercises. And if we can actually secure additional time, then you can do your ongoing LabMaP data updating. And so with that, allow me now move to the questions that are many and keep them coming. Again, I want to make a disclaimer that this session is proudly brought to you by LabCoP with the generous support from the Bill and Melinda Gates Foundation. So let me just get to the first questions. There are many and in no preferred order. I have a question from Dr. Collins Otieno, and Dr. Collins is asking that you had, both of you seem to be indicating that there was a little bit of a difficulty in ascertaining the tier levels for the private sector labs. I think also the animal sector labs, the categorization of their tier system was difficult. And so going forward, what are some of the steps you're taking to try and harmonize the tier leveling of both public sector, private sector, and also the animal sector labs? And I will start with Teresa. And Teresa, if you want to throw it to any of your colleagues, you can then call them out and they support you with this. Teresa, over to you.
Thank you so much, Francis, and also all the people that have posed the questions. So what we have started doing in Malawi regarding the categorization of the standalone labs, we have started engagement with the Medical Council of Malawi and also the planning section in the Ministry of Health, because these are the people that do guide the categorization of the hospitals. And as laboratories, we have to align our services to the level of healthcare services that are being provided at that particular facility. So it's an initiative which we are making as the lab department. In fact, that's the goodness of the LabMaP, because it's beginning to unveil some of the areas which we never thought about all this time around. So it's an activity that has to be dealt with in a collaborative manner. We cannot do it on our own, but we have to engage the other stakeholders. Just as I've said, the Medical Council of Malawi, as well as the planning section in the ministry. Thank you.
Thank you. Thank you very much. And again, just to disclaim again that the lab mapping exercise, even when we've shared here, only, I think both countries gave it that the capacity for all the other tests were mapped. And you can actually pick for each of those tests and develop your scenarios, get to know what the capacities are, where they are located, and should you desire to improve capacity for that particular test or diagnostic service, where then do you go next, or where do you place another machine or upgrade an existing machine, just so that it's clear to everyone, even when we focused on the two platforms, GeneXpert, and I think at some point the TrueNut. I also have a comment from Samuel, and Samuel is saying in the lab categorization, apart from basing it on the healthcare services level, it can also be based on the biosafety level or a range of tests that laboratories can run. This will then help you with the categorization, and that is a super comment from Samuel there. And just to note that the two levels were dealt with independently. So the biosafety level categorization and also the tier level categorization of labs, and both were actually used. And once a country desires to make a determination of where they want to improve either biosafety level categorization or the tier level categorization, they can actually get to that. So but I'll leave it to Vincent. The question on staff mobility, in your own opinion, from the Zim side, is that a key factor that you considered when you were doing the lab mapping exercise? And what are some of the considerations you're taking to make sure that even when staff are moving, the capacity in terms of human resource that you're sharing with your senior management is not skewed in any direction?
Thank you very much, Francis, for that question. What I would like to say is staff attrition is a phenomenon which is very difficult to control in many of our countries. So when we did the mapping exercise, we didn't really were worried about that because it's something that is difficult to control. However, during the data cleaning exercise, we noted that that staff attrition also affects the quality of responses that you get, because when you visit one facility, you may find that the respondent might not have enough of the information, which will also come to affect the quality of data that is collected. So to countries that are yet to do the mapping exercise, it is important to have some pre-communications so that in terms of when they get to those facilities, they are able to collect the most correct information because there were some pre-communications. And also you find that some of the staff are not moving because of leaving the place, but because of also other work-related commitments. I think for now, that's what I can say. Thank you.
Thank you very much, Vincent. Let me take it to Teresa and team. And there is a question coming in from Patience, and Patience is asking which tests that are conducted. So which tests are conducted at primary healthcare centers in your tiered laboratory network? And you can generally speak to your national essential diagnostic list while responding to this question. Teresa, over to you.
Thank you so much, Francis. So at primary level, that's where we have the basic tests that do not require any sophisticated devices. We are actually using point of care devices as well as simple equipment like we have the microscope, we have the hemoglobinometers. Of course, in some of the facilities, we also have the gene expert. So we have the basic tests that we are doing microscopy. All those are done at primary level facilities. Just as Francis has said, we have just finished developing our national essential diagnostic list, which also speak volumes about what sort of tests are supposed to be at each level of health service delivery, starting from the primary all the way to the national level. Otherwise, put it simple, at the primary level, that's where we have the basic laboratory tests that do not require any sophisticated equipment. Thank you.
Thank you. Thank you very much, Teresa. Our next question, Vincent, you can guess it's coming to you. And so it's coming from a Wandem, and a Wandem Ernest is asking, how did you integrate multiplexed platforms in your data collection process?
Okay, thank you, Francis, for that question. So like I said earlier on the selection, we prioritized that we should map the reference labs, the central hospital laboratories, and the provincial hospital laboratories. So you find that in our country, that's where we have the big throughput platforms within the diagnostic network. That's why we prioritize to make sure that all those facilities are mapped, because within those facilities, that's where we find even HIV via high throughput platforms, also other sophisticated equipment like PCR analyzers, thermocyclers, and gene sequencing equipment. That's where most of those equipments are. That's why we prioritized mapping those laboratories so that we would capture the country's capacity to respond or to provide testing to these issues. Thank you, Francis.
I hope it's not my connectivity. Have I lost you?
Thank you, Francis. I think, was I audible enough, or I need to repeat
Vincent.
the response to that? Yes, Francis, I can hear you.
We generally got you. Thank you. Tapson, can you come in and just help us with one question that relates to data quality? Given that we were using the ODK platform to relay data to the owner repository and subsequent use, did you, from the data analysis side, did you see any difficulty with using that particular platform, the ODK platform? And if yes, what are some of the the mitigation measures you were putting in place to make sure that data quality was not compromised at collection, but then subsequently after the data collection.
Yeah, so are you able to hear me?
Correct.
Yeah, so we are using the online systems because they have inbuilt validation rules, which are critical to pick issues, especially when you look at the questionnaire and you also look at the number of questions that we have. Obviously, you end up with someone that is a data collector who may get tired and lose the focus. But in the process, there are areas that you need to skip. And when you look at the tier system, you also see that from primary to reference lab, as Zimbabwe and Malawi mentioned, obviously there could be some test menu that will not be relevant in certain tier areas. So in that case, the ODK system has inbuilt validation laws that you should be able to skip where necessary if it's not relevant to the process. In that way, you are able to avoid certain issues that the data collector can do that. After that, as I mentioned on validation, when the data goes to owner, where is the storage process, we're able to extract from that system, and we're able to go through using a script where you are able to pick key issues that arises in terms of landing of the data into the system. But as I also mentioned, if you had the issue of cleaning and ensuring that data is accurate, the countries knows very well where the issue is. I mean, how do you know that the number of accredited labs in the country are 5? So you need the country insights to make sure that they're able to identify. Yes, you have the skip rules and the controls in the ODK up to the owner, but they need to be further. There's a further process where the country needs to provide insights in terms of, we only have 5. As Francis mentioned, there's some data that you already have in the country. That data is also critical to ensure that you are able to clean the data and ensure that whatever garbage in, garbage out is able to be rectified during the validation process. So these are some of the key steps that ensure that the data is accurate, both using the ODK, but at validation stage. Over.
Thank you. Thank you very much, Tapson. And we are at the top of the hour. Let me now just hand it over to Teresa. You started us, and let you be the first to do your closing remarks in about 15 seconds.
Thank you so much, Francis, and thank you very much, everybody on the call. I think my only closing remark is to say, I think that laboratory mapping is an important step in strengthening laboratory systems and also the network. And as a member states, we can think of consider doing one as we think of our lab systems. And I'm optimistic that if Malawi was able to do it, then everyone else can do it. It only takes the determination and also commitment. The support is there. I mean, people are there, stakeholders are there to support us, just as it happened with us. Thank you very much.
Thank you. Thank you very much, Teresa. Now, immense appreciation for your sharing of your experience from Malawi. Let me hand it over to Vincent to just wind it up. Your closing remarks in about 15 minutes as well. 15 seconds, sorry.
Thank you, Francis. I would like to thank everyone who has joined this meeting. I would like also thanking our ASLM team and Africa CDC for the support they've given us, and also to other countries that are yet to do their lab mapping exercise. Lab mapping is fun and it is good. It shows where you are standing as a country in many areas. And I would like to say to those that are yet to do their mapping exercise, it is possible. It's not out of this world. And please be committed and take note of the fact that garbage in, garbage out. So be very vigilant and collect data as best as you can. Thank you, everyone.
Thank you. Thank you very much, Vincent. Our great appreciation to you and the team as well. Now, but with those, allow me thank you so much for being part of this. Until those sessions, we wish you the very best of your morning, afternoon, or evening, depending on where you're joining us from. Thank you very much.